Okay, so today's lecture, which is our last or final lecture of DAN 160, is chapter 35, which starts on page 426 of your dental radiography textbook. This deals with the interpretation of trauma, pulpal lesions, and periapical lesions. So what we're going to talk about here is the appearance of the roots, the crowns, and jaw fractures as viewed on a dental image. We'll talk about the appearance of luxation and an avulsed tooth, also the appearance of external and internal resorption, pulpal sclerosis, pulpal canal obliteration, and pulp stones, as well as periapical radiolucencies such as periapical granulomas, cysts, abscesses, as well as periapical radiopacities, and describe and identify the appearance of condensing osteitis, sclerotic bone, and hypercementosis. So the whole purpose of this chapter is to provide a brief overview of the common features of trauma and pulpal and periapical lesions as viewed on the dental image. So changes associated with trauma, resorption, and pulpal and periapical lesions can all be viewed on dental images. Trauma may result in fractures of the jaws and the teeth, as well as the displacement of teeth. And trauma is an injury produced by some type of external force. So it can be the crowns and the roots of the teeth, as well as alveolar bone. It may result in injuries of teeth and bone and injuries such as intrusion, extrusion, and avulsion. And trauma can also be viewed on dental images. So we'll go through each one of these. So fractures can be defined as the breaking of some part. So they may affect the crowns and the roots of teeth or the bones of the maxilla and mandible. These can include, but are not limited to, crown fractures, root fractures, and jaw fractures. Whenever a fracture is evident or suspected, an image examination of the injured area is necessary. Crown fractures most often involve the anterior teeth. I'll say this again. Crown fractures most often involve the anterior teeth. They can involve enamel, dentin, and or pulp. And the dental image prevents evaluation of the proximity of the damage to the pulp chamber and evaluation of the root for any additional fractures. So most crown fractures result from accidents involving some type of fall or motor vehicle accident or something of the like. Figure 35-1 shows a crown fracture. And here we can see an actual break in the tooth. This patient here would have been lucky because the crown fracture does not extend into the pulp chamber, but oftentimes this isn't the case. A lot of times when we see these things, such as in a car accident or something similar, the crown fractures right through the pulp chamber, which causes extreme pain for the patient. Root fractures most often occur in the maxillary central region. They may be vertical, horizontal, single, or multiple. If the X-ray beam is parallel to the plane of the fracture, it will appear as a radiolucent line. But if the X-ray beam is not parallel to the plane of the fracture, it may not be apparent at all. So these are less common than crown fractures, and they usually result in some type of an accident or traumatic blow. With time, root fractures have a tendency to enlarge because of the displacement of root fragments, hemorrhage, or edema, which is swelling. So figure 35-3 shows an example of a root fracture, and here we can clearly see a fracture that's evident on the root surfaces of the teeth. But this is not always the case, especially if these root fractures happen to be vertical. We may not see these at all, and it would have to only be diagnosed by some type of external or 3D imaging or by an endodontist with a microscope. Jaw fractures are most often observed in the mandible. The panoramic image is the best film for visualizing mandibular fractures. And on the dental image, the fracture appears as a radiolucent line. Maxillary fractures are typically difficult to detect on dental images. And these are frequently result from some type of assault, accident, or sports injuries. This is because of how traumatic the blow has to be in order to fracture the jaw. Maxillary fractures occur less frequently and most often involve the anterior alveolar bone and teeth. So figure 35-5 shows a fracture of the alveolar bone. And here we can clearly see that the bone surrounding the tooth is what is in fact fractured. And they are more common in the mandible, since the mandible is the movable part of the jaw, and they often take the most force in an accident that would result in one of these. Trauma may result in the displacement of teeth, so this has to deal with luxation. And luxation can either be intrusion or extrusion and avulsion. Dental images allow the evaluation of structures after tooth displacement. Luxation is the abnormal displacement of teeth. Intrusion is a type of luxation, and it's the abnormal displacement of the teeth into the bone. So this is what happens when the teeth get pushed into the bone. Extrusion is the abnormal displacement of teeth out of the bone. So the opposite of that will be the teeth coming out of the bone. Teeth that have been luxated should be evaluated by a periapical image and examined for root and adjacent alveolar bone fractures, damage to the periodontal ligament, and pulpal problems. So here we have figure 35-7, and it shows an example of an intruded crown. So this crown has been intruded. This person probably took a blow to the face while their mouth was open, I'm assuming, and it actually pushed the tooth into the bone. As you can imagine, that is a very painful thing to happen. Thankfully, the tooth can most likely be saved with orthodontia and or surgery, but it would still be a very painful condition. Figure 35-8 shows a partial avulsion or an extruded crown. Avulsion just means when the tooth comes out of the bone. And here we can see a partial avulsion. The tooth has been partially avulsed. It's almost out of the bone, but it's still attached. This was another painful situation. It's almost as if the patient underwent a very traumatic extraction, but the tooth is actually still in the bone. So a complete displacement of a tooth from the alveolar bone is known as dental avulsion. Here we have a periapical image that shows a tooth socket without a tooth. So this results from trauma associated with an assault or accidental fall. Dental images are important in the evaluation of the socket areas and should be used to examine the region for splintered bone. The pathologic resorption of teeth can be described as external, internal, depending on the location of the resorption process. Physiologic resorption is a process seen with the normal shedding of primary teeth. Pathologic resorption is a regressive alteration of the tooth structure observed when a tooth is subjected to abnormal stimuli. And this can be from external absorption or internal resorption. And we'll go through examples of each one. So the primary tooth is shed when resorption of the tooth is complete. So here we have an example of pathologic resorption where we have a primary tooth or a baby teeth that are still in the mouth. And below it, you can see the permanent teeth growing under. And this is causing pathologic absorption. And this is a normal process of the patient shedding their baby teeth and they're growing their permanent teeth in. External resorption is seen along the periphery of the root surface. This is often associated with reimplanted teeth, abnormal mechanical forces, trauma, chronic inflammation, tumors and cysts, impacted teeth, or some other type of idiopathic cause. It most often involves the apices of the teeth. This is when the apical region appears blunted and the length of the root is shorter than normal. So both the lamina dura and the bone surrounding the blunted apex appear normal. It's not usually detected clinically and does not exhibit mobility where the tooth does not appear loose. Here there is no effective treatment. So here is an example of external resorption where the root surface has actually been shrunken down. This usually doesn't cause any type of symptoms with the patient, and there's nothing that can actually be done here. It's just something that is watched to make sure that no other lesions result in a condition like this. Internal resorption results within the crown or root of the tooth. It involves the pulp chamber, pulp canals, and surrounding dentin. It is believed to be precipitated by factors such as trauma, pulp capping, and pulp polyps. It appears as a round to ovoid radiolucency in the mid-crown or mid-root portion of the tooth. Endodontic therapy is usually recommended if perforation has not already occurred. So these are generally asymptomatic, meaning there's no symptoms with the patient. Treatment is variable, although it's usually not very successful. And if the tooth is weakened by the resorptive process, an extraction is usually recommended. So here we see a radiographic example of internal resorption. And so what it'll look like is right in the middle of the pulp chamber, we see this kind of ovoid or round radiolucency right where the root structure will be. So a lot of times this is asymptomatic. It's not going to cause any symptoms for the patient, but it is something that would need to be watched. So examination of the pulp chambers and canals is impossible without dental images. That's because these may detect conditions such as pulpal sclerosis, pulpal obliteration, and pulp stones. So many dental procedures require information about the size and location of the pulp cavity before treatment begins. Without dental images, examination of pulp chambers and canals is impossible. So here's an example of pulpal sclerosis. This is a diffuse calcification of the pulp chamber and the pulp canals of the teeth. It results in a pulp cavity of reduced size. So it is associated with aging. As people get older, their pulp canals and their nerve canals start to shrink. And so we can very faintly see the actual canal of the teeth here. There is little clinical significance unless endodontic therapy is indicated. If this person were to need a root canal, it would be very difficult just because it would be difficult to get through the canals of the nerve. Pulpal obliteration is when the calcification or the deposition of hard tissue within the pulp cavity becomes so much that basically the pulp disappears entirely. These teeth are considered non-vital and do not require treatment. This may be caused by attrition, abrasion, caries, dental restorations, trauma, or abnormal mechanical forces. Here, the tooth does not appear to have a pulp chamber or pulp canal. So if we look at figures 3515 and 3516, this first one shows, if you look at tooth number 8 here, there is actually no pulp visible here. Whereas in number 9, we can clearly see the pulp chamber and the root canal here. We don't see it here. And so this would be a visual representation of a non-vital tooth. The tooth often becomes discolored, gray, or brown. That is because the tooth is clinically dead. Usually doesn't cause any type of problems with the patient unless there becomes an abscess around the tooth. Here, there would be no root canal to go through, so the tooth would have to be extracted. Pulp stones are dystrophic calcifications found in the pulp chamber or pulp canals. They appear in dental images as round, ovoid, or cylindrical radiopacities. They may vary in shape, size, and number. They do not cause symptoms and they do not require treatment. So on a dental image, pulp stones appear as round, ovoid, or cylindrical radiopacities. And here we can see an example of some radiographs. This is a cylindrical pulp stone. Here we can see the pulp chamber. It looks literally like a small stone that's lodged inside the pulp chamber. Another anterior shot here. This looks like tooth number 7. And we see another pulp chamber or a pulp stone right in the pulp chamber there. Periapical radiolucencies include periapical granulomas, periapical cysts, periapical abscesses, and periodontal abscesses. When we're talking about periapical radiopacities, these can include condensing osteitis, sclerotic bone, or hypercementosis. So a periapical lesion is something that is located around the apex or the tip of the root of a tooth. Periapical granulomas, cysts, and abscesses are commonly seen on dental images. These lesions cannot be diagnosed on their dental image appearance alone. Diagnosis is based on clinical features and dental image and microscopic appearance. So a definitive diagnosis can be established only with microscopic examination. A periapical granuloma is a localized mass of chronically inflamed granulation tissue at the apex of a non-vital tooth. So this is a tooth that is no longer live or has had a root canal. So it is most common secula of pulpitis. It may give rise to a cyst or to an abscess. Treatment is either endodontic therapy, which is a root canal, or removal of the tooth with curettage of the apical region. On the dental image, it appears as a widened periodontal ligament space at the root apex. So here we have some radiographic images here. Here, this results from a pulpal death or necrosis or inflammation of the pulp. These are typically asymptomatic, but sometimes have a history of prolonged sensitivity to heat or cold. Here we can see tooth number 7. If you look right around the periodontal ligament space, it is actually widened. This is this radiolucent line around the tooth. If we look at the rest of the teeth, we don't see that, but on tooth number 7, it is widened. Here we can see this is a more advanced I guess, situation here. Here, the lamina dura is not even visible on the root of the apex and the apical lesion. We actually see a nice big apical radiolucency around here. So that is what a granuloma looks like. A periapical cyst is a lesion that develops over a long period, usually results from cystic degeneration of the periapical granuloma. It is the most common of all tooth-related cysts and is typically asymptomatic, meaning there is no symptoms, and treatment is either endodontic therapy or extraction with curettage of the apical region. So these periapical cysts are also known as radicular cysts. In this top image, we can see the lower anterior tooth. We can clearly see an apical radiolucency around the tooth. Here is a more exaggerated example of this. This is a huge, gigantic cyst on the mandible of the teeth. It can sometimes be mistaken for a tumor. And just from looking at the radiograph alone, it's not enough to diagnose whether or not it is a tumor. Something like this should be sent to an oral surgeon to be evaluated by some type of biopsy. A periapical abscess is a localized collection of pus around the apex of the non-vital tooth. This can be acute, meaning it's painful, or non-vital, usually sensitive to pressure, percussion, which means tapping, and heat. This may not appear on a dental image, but usually it does. Chronic, usually asymptomatic, is where we have pus that drains through the bone or the periodontal ligament space. It usually appears as a round or ovoid apical radiolucency. And here we have some, this is a minor example of periapical abscess. Here, this tooth had a huge, ginormous pulp chamber. It was almost asking to have a root canal. Here, the dentist, when they placed this big filling here, they actually went inside the pulp chamber, which not surprisingly caused this tooth to become infected. And we can clearly see this radiolucent kind of halo around one of the apices of that tooth. This results from pulpal death, or when the pulp of the tooth dies. This is usually very painful with acute abscesses, which may be intense, throbbing, and constant. So usually when people get the classic toothache, it's because they have one of these. And here we can see a little bit more clear in these teeth here, especially this tooth. And it looks like we had some type of root decay. So here's decay that happened underneath the CEJ, and it caused that cavity to extend into the pulp, down the pulp chamber or the root canal, and cause an infection here at the tip of the apex. So it's actually now into the bone, which is very painful. A periodontal abscess is a collection of pus that results from infection within the periodontal tissue. So these are tissues surrounding the tooth. It is usually an acute destructive process and occurs as a complication of advanced periodontal disease, appears as a radiolucent area along the lateral aspect of the tooth. Its most common symptom is a deep throbbing pain. Therapy includes drainage, subgingival scaling, and debridement of the periodontal tissues. Here's a radiographic example of a periodontal abscess. And here we see that abscess formation that is actually forming around the entire root structure. So the difference between a periodontal abscess and a periapical abscess and a periodontal abscess is that the periapical abscess is a collection of pus that results from a necrotic pulp or a pulp that has died within the tooth. A periodontal abscess is a collection of pus that results from the infection of the periodontal tissues, which are tissues surrounding the tooth. The following are a few of the common periapical radiopacities that may be seen on the dental image. So these may be diagnosed based on their appearance, clinical information, and patient history. And they include condensing osteitis, sclerotic bone, and hypercementosis. So any of these radiopacities found near an apex or tooth apex may be diagnosed based on the characteristic dental image findings and corroborating clinical information. Condensing osteitis is a well-defined radiopacity that is seen below the apex of the tooth with a history of long-standing pulpitis. So it may vary in shape and size, does not appear to be attached to the tooth root, and the most common periapical radiopacity observed in adults, and it's most commonly in the mandibular third molar area. So figure 35-27 shows us a radiographic image of condensing osteitis. And here we see that radiopacity around the tooth. This is usually from the tooth being, or the pulp becoming inflamed over and over again. And it will cause this to happen. So the opacity represents a proliferation of periapical bone that is the result of a low-grade inflammation or mild irritation. No treatment is usually necessary with these as long as the symptoms remain asymptomatic. Sclerotic bone is a well-defined radiopacity seen below the apices of vital non-carious teeth. So these are teeth that don't have any cavities. They happen for reasons unknown. It is not attached to the tooth. It can vary in size and shape. The margins may be smooth or irregular and diffuse, and it is often asymptomatic. So here on figure 35-28, we see a radiographic example of sclerotic bone. This is usually discovered on a routinely taken image. This is also known as osteosclerosis or idiopathic periapical osteosclerosis. And once again, it's not symptomatic. It's usually something that is just discovered when we're taking images, just something that needs to be watched. Hypercementosis is the excess deposition of cementum and root surfaces. This may result from supereruption, inflammation, or trauma. These most often affect the apical area, which appears enlarged and bulbous. The affected teeth are vital and do not usually require treatment. So here in figure 35-29, we see a radiographic representation of hypercementosis. Here, the root areas affected are separated by periapical bone by normal appearing periodontal ligament space, and the lamina dura appears normal. So this is just a very bulbous looking root. There's usually no symptoms involved. And once again, it's just something that needs to be watched. The dentist will routinely look at the lamina dura and the periodontal ligament space to make sure they're all appearing normal throughout any normal examinations. Okay, that's all I have for this chapter. This was the last one. Congrats. Good luck on your final.